Thank you, Kate. So I've been tasked to talk about frailty in 10 minutes today. It's a big topic, so I'll do my best to cover it. And thank you for that kind introduction, Kate. So a little bit about background on frailty. So it's been about 9 years since I finished medical school, and I must say during my training, I didn't get nearly enough formal education on frailty. I felt like there was a lot of complacency and resignation in terms of our approach to frailty and whether or not it's something that is something we can intervene on. But after looking at the literature and being more familiar in taking care of frail patients, it seems that there is a lot we can do for these patients. So a little bit about the background in epidemiology. Frailty is really common in our older adult population, and somewhat arbitrarily we define that as people that are 65 and older. Up to 20% of adults living in the community are considered to be frail, and up to 2/3 of these patients that you see in the long-term care setting are frail as well. And when you get up to 85 years of age, 1 in 4 individuals are frail. And being a woman, and if you're in a lower socioeconomic group, increases your risk of developing frailty. And even though frailty is common, even more common is the state of pre-frailty, or people who are at risk for progression to frailty. So why does frailty matter? So frailty is quite predictive, and very predictive, I should say, of many adverse health outcomes that I have listed here. So falls and injurious falls are more common in people who are frail compared to those who are non-frail. Frail patients who are admitted to the hospital have higher risk of delirium. They are in general at higher risk for hospitalizations, and when they're discharged, at higher risk for readmission within 30 days. They're at higher risk for having complications due to surgery or procedures. They are at risk of developing a disability related to their activities of daily living and progressing to require dependence for their functional living. More commonly, they're enter nursing homes and have a higher risk of death. So how much risk of mortality does frailty confer? In studies, they've shown that frailty increases your risk of death twofold. And even when you control for the patient's age, their sex, their comorbidities, or their self-rating of their own health, this risk of mortality still persists, which underlies that it is a distinct syndrome that is not completely dependent upon age alone. And this is important because, as we all know, the population is rapidly aging. And as we anticipate with that, frailty will as well increases with the population. And with those associated adverse health outcomes related to frailty, this will pose many challenges, not just for patients and their caregivers, but with the healthcare system and public policy as well to address the care of these patients. So it's important for us to be able to recognize and diagnose frailty, to identify a subset of patients that are high risk of these adverse health outcomes, who may then require extra medical attention, support, and resources available in the community. For example, programs like all-inclusive care of the elderly, or what we are trying to establish here at Harborview, a patient-centered medical home. So a little bit about the pathogenesis of frailty. So many things contribute to the development and progression of frailty. A subset of patients who are older are predisposed, I would say, to an accelerated aging phenotype that leads to frailty. And in these folks, the common theme is that they have chronic inflammation associated with aging and changes in their regulation of hormones. So reduction in androgens such as testosterone, growth hormones, that insulin that confers reduction in muscle mass and composition, a term that we define as sarcopenia. This in older age is a vicious cycle when people are hospitalized and put on bed rest or they're malnourished. And it promotes this vicious cycle of progressive muscle loss and weakness. Important to recognize is that the majority of patients who are frail have underlying cardiovascular disease. And it may not be overt in terms of symptoms, but we know that a lot of these patients have what we call subclinical cardiovascular disease. And it's thought that that also contributes to the progression of frailty. You also have people who are predisposed because of genetics and environment. And this leads to progressive deterioration in physiologic function that when stressed, people decompensate in terms of their function. And all these factors contribute to this phenotype of frailty that we see in our patients that's characterized by a slowing down of their mobility or gait, weakness, generalized weakness in terms of muscle strength, weight loss, as described as shrinking, which is unintentional weight loss, inactivity or poor mobility leading to fatigue, exhaustion, and poor stamina. As I mentioned, frailty is a syndrome, and like other geriatric syndromes, it has, by definition, multiple factors and contributors that are dynamic. So people can progress from a pre-frail state to a frail state, or progress from mild frailty to severe frailty. And in some patients, you can progress and reverse that potentially from being frail to pre-frail or frail to robust with interventions. And when you combine these age-related declines with physical and organ function with aging, with some of these drivers of frailty, such as the chronic inflammation we talked about, these neurohormonal changes that occur, frail patients become very susceptible to decompensation of their health with minor or major stressors. And they can be minor, such as a drug side effect can lead to decompensation. So much less infections or MI, things that are major. For frail patients, even something very minor as a medication change or drug side effect can tip them over. It's important to know that frailty, just looking at someone, their physical appearance is not very sensitive to detecting frailty. And we're recognizing this more frequently in our patients who are overweight or obese, is that they actually, a lot of them are frail because their muscle mass is not able to be assessed clinically because of the excess adipose tissue. So outward physical judgment, or this Gestalt approach to identifying people are frail based on their physical appearance, is not very sensitive. And as I mentioned earlier, frailty exists on the spectrum that's dynamic, and people can change and based upon how they're doing. And progresses to a state of failure to thrive, and ultimately inanition and death. So in terms of screening for frailty, consensus guidelines have recommended that we do screen for frailty in everybody that's 70 years or older, and those who have chronic medical conditions and experience a 5% or more unintentional weight loss in the past year. However, there's been no recommendation as to what specific assessment tool we use, just to pick one. I think the caveat is important to recognize is that the assessment tools that we pick and use has to be specific to and validated in the patient population that you're seeing. And I'll talk a little bit more about the tools. So there are many dozens of frailty tools that exist in the literature. I'm going to present the ones that have been the most rigorously studied and validated. And the first is Fried's phenotype of frailty. This was determined by the cardiovascular health study of cohort of patients. And they defined frailty as meeting 3 of 5 of the following features. So an unintentional weight loss of 10 pounds or more in the past year, the patient's self-report of feeling exhausted or tired, a slow gait or walking speed, low physical activity or endurance, and weakness. And in this study, it was measured by hand grip measurements. And a pre-frail state was defined as people meeting 1 or 2 of those features. And this phenotype was predictive of adverse health outcomes in this community-dwelling older adult population. Another well-recognized conceptual model and assessment tool for frailty was developed by ROCKWOOD, and he developed a frailty index. And his concept was that the more deficits that a person accumulates in not just one domain, but multiple domains of function, from physiologic to psychological and social, that if we quantify that by the number of variables that we're measuring, we're able to calculate this frailty index. Now you can see there are over 40 variables that's measured, so it's not very easy to implement something like this into routine clinical practice. So, and it also doesn't account for cognitive impairment, something we see frequently in our older adult population. So him and his group develop a scale, which is a visual scale that does account for cognitive impairment. And this was well validated in a hospital setting in medical and surgical patients. So here's the clinical frailty scale, which is something that I've adopted in studying our patients here at Harborview to see who can benefit the most from geriatric intervention. And it's, I feel, an easy scale to rapidly use to screen and assess for frailty. And important here, again, is that frailty corresponds to the degree or severity of dementia. The International Academy of Nutrition, Health, and Aging adapted Fried's phenotype and ROCKWOOD's criteria to a frail scale, which with the mnemonic is easy to remember: fatigue, resistance, ambulation, illness, and loss of weight. Illness being defined as having 5 or more chronic medical conditions. And again, meeting 3 of those 5 being defined as frail, and less than 3 as pre-frail. So frailty, because it's a clinical diagnosis, there's no test that we can send in a lab or biomarker. There's not yet a validated imaging test that we can use. Because it's a clinical diagnosis, it is by definition a diagnosis of exclusion. So when people present with fatigue, weakness, weight loss, there's a very broad and wide differential of potential conditions that could present in the same manner that needs to be systematically evaluated and put those potential conditions excluded. So a general workup I feel for frail patients or people you suspect who are frail, easy things to get a good sense of how frail they are by exam is to have them perform sit to stand in a chair without using their arms, and how fast they can do 5 of those repetitions. And gait speed is an excellent predictor as well of adverse health outcomes. And generally we do that by a timed up and go test. How long it takes for the patient to rise from their chair without arm support, walk 15 feet and back and sit down. And also grip strength. Even if you don't have a tool to actually measure their grip strength, I think some objective sense of you can gather as well from your impression of their grip strength. Basic laboratory workup, a complete blood count, a complete metabolic panel with nutritional markers such as pre-albumin or albumin, B12 levels, or if they're on the low end of normal, a methylmalonic acid level, 25-hydroxyvitamin D level, and a thyroid stimulating hormone. Patients should have age-appropriate cancer screening as well, and additional workup based on risk factors and on additional features you find on history and exam. So interventions that we have available for frailty. A comprehensive geriatric assessment to identify other geriatric syndromes, potentially reversible causes of frailty, a fall assessment and fall prevention, a nutritional assessment and intervention, and physical interventions have been shown to have beneficial effects for frail patients. And this can be done in a supervised or home setting, and it's important to include both aerobic physical activity along with muscle strengthening and balance, with the goal to advance as tolerated both the intensity and duration and frequency of these interventions. A lot of research is being done now to look at pharmacologic interventions that can mimic the beneficial effects of diet and exercise without doing the diet and exercise.
Everyone's looking for that.
Yes. And I suspect in the next decade or so that such interventions will be available based on the pace of the research. So a little bit about how we care for frail patients who are hospitalized. I think it doesn't differ very dramatically from older patients in general, but I think these patients require more heightened surveillance and just going through these pathways of care with a fine-tooth comb to make sure that all of these things are being done appropriately. So delirium prevention, avoiding polypharmacy, making sure their pain is well controlled, and establishing very clear goals of care for these patients, along with the other things I have listed. So important to recognize that one person, one provider is not going to be able to take care of frail patients on their own. Okay, so it requires a very interdisciplinary, multidisciplinary effort to provide the best care for these patients, to minimize the risk of adverse health outcomes and improve their quality of life. And important in that is understanding their values, their goals, and priorities of care, to identify a surrogate decision maker, start the process of healthcare planning and advance directives. And it's also important to set realistic expectations about risks and benefits and burdens of potential interventions. And you know, frailty is not a reason for us to deny care for patients, and it should allow us to reframe care and develop different approaches if aggressive interventions, the risks of those outweigh their potential benefits. So in summary, frailty is a syndrome, a clinical syndrome that's very common in our older adults, and it significantly impacts upon them, their caregivers, and confers a high risk of adverse health outcomes. And with rapid population aging, frailty is going to pose increasingly significant challenges to our healthcare system and providers. And important to remember that frailty is a dynamic process, and it is potentially reversible. And because of multiple factors and contributors that drive frailty, it's important to institute interventions that are also multimodal, that target both exercise, physical activity, nutrition, and psychosocial health and well-being to prevent and treat frailty, and with the hopes of improving the quality of life for these patients, their experience of care, and to reduce healthcare costs. And I'm happy to take any questions, and I thank you for your attention.